Okay, so I just want to say welcome to everyone. It's good to see everyone. And getting ready for the HESI here. Okay, I just wanted to see everybody. Now I'm going to start out. I'm going to go over some 4 areas that are important. So I think a lot of times when you start out and you know how HESI is put together, then you have a good idea of how to study for this HESI. All right. And remember, I told you that HESI review book. I had it up before. This one is your partner. Okay. You want to have this close to you all week. All right. And by the time you get done, you will feel very confident to take the HESI. Okay. All right. So I'm going to share my screen and we're going to go over some areas of the HESI. All right. All righty. So I'm going to get this. Okay. So let me just make this a little bit bigger for you. There you go. So you have, in order to prepare for such a national exam, you have to know there's 4 areas on the HESI exam that we look at, or they look at. And that's the safe and effective care, health promotion and maintenance prevention, psychosocial integrity, and physiological integrity. So think about it, okay? They're looking at safe and effective care. So these questions would be mainly about patient safety. Okay. So when you're looking at these questions, the nurse prioritizes the delivery of patient care. All right. You're always prioritizing. So ask yourself this question when you're taking these tests. Ask yourself, if I can only choose to do one thing, what would it be? Okay, and remember, you got that ABC, right? Airway, breathing, and what else? Circulation. All right, because without circulation, guys, without an open airway, we got nothing, right? Okay, and without circulation, we're nothing. So implement seizure precautions for like an at-risk patient. So think about the complications that could cause a seizure. What in maternity do we worry about that the patient could have a seizure if we don't do things very quickly?
Eclampsia?
Yes, the preeclamptic patient. Clarenzia, did you raise your hand?
Oh, yeah, I was going to answer, but everybody answers fine.
Yeah, okay, all righty. So preeclampsia, yeah. So you want to, make sure that you remember to keep her safe. So for seizure precautions on a patient, what we're going to do, we're going to pad the side rails, right?
Yeah, pad the side rails.
Yep. And what else? Keep the call button right there, right?
And have succedaneum ready.
Yeah, have everything ready. Yeah. Make sure that you have all your, even this wall suctioning ready, make sure that you're there for prevention of a seizure. What medications, since we're talking about preeclampsia, what medications medication do we use for a preeclamptic patient?
I see.
Magnesium
sulfate.
Magnesium sulfate. Great. And what about magnesium sulfate? Since it's a central nervous system relaxant, it relaxes like everything. Could she get too much of magnesium?
Yes.
Yeah.
Yes.
Yeah, you get magnesium sulfate toxicity. So what would I have at bedside?
Calcium gluconate.
Yeah, calcium gluconate. You got it. Okay, so you see where I'm thinking, see how these questions could go? All right. So now, and also for security, and remember, for OB, for maternity, we always have security plans and procedure for the newborn, okay? We have the ID bands, okay? And they do like to put a question about ID bands. And you know that there's four parts of that ID band. 2 go on the baby, and 1 goes on mom, and 1 goes on the selected person that she wants to have the other ID band. And all those numbers all have to match. Okay. All righty. So now we're going to think about some postpartum complications, such as postpartum hemorrhage. We're going to go over hypovolemic shock, uterine atony or atony, a uterus without tone. And what would the nurse assess on this type of patient? What would I be worried about with uterine atony?
Placenta fragments still left in the uterus.
Yeah, what condition would that uterus be if that uterus didn't have tone?
Soft and
Boggy.
Soft and foggy. Yeah. So what would the nurse do?
Massage
Massage the fundus.
Massage the fundus. Okay, good. All right. All right. And then Nagel's rule. I'm going to tell you guys, been doing this for a long time, about 7 years. Every quarter, every HESI, there's always a Nagel's rule. So it's easy. You want to basically count back, 3 months from the first day of her last normal menstrual period. Okay. Now, remember that it's the first day, right? And they like to put a scenario, and they can put, they can put all kinds of different stuff in there, but you want to make sure, okay, what is her first day of her last menstrual period? Okay, there it is. And then you're going to count back 3 months. And then you add 7 days to that first day of the last menstrual period, right? Got it? So, and then if you have to, if you got to say the months out loud, just say the months out loud, we're on a piece of paper at least. Okay. And then they always have a question on gravity and parity. All right. So remember, gravida is what? What does gravida mean?
number of times the woman been pregnant, whether the baby made it or not, or etc.
Exactly. Good. Good. And para?
Number of viable pregnancies.
Pregnancies as reached past viability.
Right. Very good. Very good. Now, if you forgot about that, just go into your HESI book, and it's in there very, very nice. Okay. So we're going to go right into health promotion and maintenance. Maintenance continued. All right. So I'm going to provide care and education to an antepartum client or a client in labor. So when giving care to this client who's an antepartum, that means before delivery, right?
Mm-hmm.
You want to look at the different trimesters. Okay. So the first trimester, that's week what? Week 1 through, how long are the trimesters?
8 weeks.
3 months.
13 weeks, right? Okay. So you got 13 weeks. So first trimester is week 1 through the 13 and 6/7. So how does the woman feel during the first trimester? She's kind of ambivalent about the pregnancy, right? Not everybody is kind of happy-go-lucky about it, and they could have some therapeutic communication questions on that. And they may have some on financial concerns and even career concerns. And remember the different groups we were talking about. We had the adolescent group, we had the advanced maternal age group, and we had the different groups that have all their unique problems. Okay. But we get them through that. Okay. They come in and we get them through it. And if they're advanced maternal age, they may be wanting to do some chromosome analysis. What's the test that we do for chromosome analysis?
Is it amniocentesis?
The amniocentesis.
Amniocentesis. Very good. Okay, good. Okay, very good. And that gives you a good clue about those chromosomes lined up. And it gives her, that's really a diagnostic test. That gives the patient an idea of what's going on. Now, second trimester. Okay, this is where we call it the honeymoon trimester, because during the first trimester, not only does she have all this going on, but she's also feeling kind of nausea and vomiting, right? She's not feeling too good. So if we get them through the first, we get to the second, and we got the honeymoon stage. Okay, and then what's quickening?
Feel the baby move for the first time.
Yeah, the baby moves, and that's when I tell you, and I tell you, that's when the woman really associates with the baby, is when they actually now feel it. Because don't forget, in the first 10 weeks, that uterus is very small and it's going to grow right out of the pelvis and into the abdominal cavity, right? And so it's, you know, she knows she's pregnant, but does anybody see it now? You know, does she feel it? All she feels is nausea, vomiting. And so when this happens, this is a special time. And then it's the only time when this happens too that she actually says, you know, I really am pregnant. I've had patients that tell me that. They've had I'm sitting down with them and they go, you know, now I feel like I'm pregnant. So I go, okay, that's good. We did an ultrasound. That was a pretty positive sign, that ultrasound. Okay, and then we go into the third trimester. And now she's mainly focuses about herself, right? And the labor process. I had one lady says, you know, I gotta think about this. I gotta go through labor. And that's when we take the opportunity to try to get them to a prenatal class. The more they go to classes, the better, because then they have a good understanding of what labor and birth is all about. Okay, now for a woman who's in labor, I'm just going to get some water here. You want to think about contraction pattern. What's a good contraction pattern?
Regular.
Okay, regular rhythmic contractions, right?
Yeah.
You know, the real Neil, Nurse Patel, did you raise your hand?
Yes, I was gonna ask, so you give the prenatal classes in the first trimester?
You got, I didn't hear that. I'm sorry.
You give the prenatal classes in the first trimester?
Not the first. We wait till we get back in this honeymoon stage, the second.
Okay.
Yeah,
Okay.
it's kind of too early in the beginning. But you know what the ladies do? There's some really good books out there. And they go on and there's what's a really good book I'm thinking about? All you want to know about being pregnant, you know, is some really
What to
good
expect
books.
when expecting.
Yes, exactly. Thank you. Those are really good books. I tell you, they are. Okay. So we want to think about contraction because now she's thinking about labor, right? So we want to have a good contraction pattern, regular contractions, frequency. I want it every 2 to 3 minutes apart. Okay, good contraction pattern. And duration, 60 to 90 seconds. That's how long they last. So if you're not familiar with the term frequency, be sure to look that up again. Remember, frequency, you take from the beginning of one contraction, right, and go to the next contraction, okay? So that's how often the contractions are coming. Duration is the beginning of one contraction to the end of that same contraction. That's how long they're lasting. All right. Now, to know we're in labor, true labor, we're going to have dilation and effacement of the cervix. So dilation goes from 1 centimeter all the way to 10. And then effacement goes from 0 to 100% effacement of the cervix. You know, the cervix, when you're pregnant, is very long. Okay. But when you go into labor, the cervix actually thins out. And actually the internal os goes up more, and then the external os will come up where the internal os was, and it all comes wide open for the baby to descend. And that's what we call that baby coming down. Just remember the station of the head and how it descends into the pelvis. Okay, the ischial spine is what? 0 station. Anything above the ischial spine would be what? -1, -2, -3, right? Anything below the ischial spine is a plus. Okay. All right. So what's the normal fetal heart rate?
110, 160.
110 to 160.
160.
110, 160. So anything below 110 would be called bradycardia, and anything greater than 160 would be tachycardia. Okay, so I put in here, understand veal chops. So tell me, what are, okay, remember veal chop? Okay, variables. What are variables caused by? Or
Head
what
compression.
causes a variable? Huh?
Head compressions. I'm
Mm,
sorry,
no.
cord compressions. Cord
Cord compression.
Good, cord compression. You got it. Okay, now the next one, early deceleration.
Head compressions.
Head compression.
Right, you got it. Is head compression. And then we got what? Let's see, VEA. Oh, acceleration.
Okay.
Ah, right, they are okay. Good deal. And then we got L. Ooh,
Placenta
Placenta deficiency.
insufficiency.
right, that's a call, late deceleration, and that's caused by uniplacenta insufficiency. Yeah, and the baby cannot really does not do well when you have recurrent late decelerations because the baby's not getting the oxygen it needs. They're not getting the perfusion, the blood. So because the uterus and I always said the uterus and the placenta, they're just not getting along, you know, and so they don't want to service each other. So the poor baby goes, "Hey, what about me in here?" And I'm going to let somebody know. So the baby communicates to us through how their monitor strip, how their heart rate goes. And they're going, "I'm not doing too good in here." Okay. Now we have another reminder, the term lion. Remember when we have fetal distress, we're going to follow this, right? So what does L stand for? Put the patient in a lateral position, right? And preferably left lateral because you get better perfusion of blood. Okay. I stands for you want to have a line in your patient. So how about an IV? Okay. And then O, what do you think O stands for?
Oxygen.
Oxygen. Good. Oxygen. Yeah. And usually 8 to 10 liters via a tight face mask. Okay. No nasal cannula in maternity. They just don't work well because we got to get this oxygen, not only to mom, but we got a baby inside that needs that. All right. And pain. Now, how does the nurse help the patient who's experiencing pain? So let me give you something. You have a patient this is her first baby, and she doesn't want any pharmacological methods. You know, she's coming in very stoic and says, I don't want any of that. I just want to have non-pharmacological. What would you suggest to her?
Breathing, tub.
Okay, breathing is good. Mm-hmm.
Touch
You can get in the
stimulation.
tub.
Get a tub, hydrotherapy, absolutely. That's one of my favorites because it works so very well. And the shower works just
And-
beautiful. Okay, what's
I like
another
that.
one?
Touch
Starts with an
stimulation.
E. I don't know how to pronounce that.
Anybody can help her? She's rubbing her tummy.
Effleurage.
Effleurage.
Yeah.
Yes, effleurage. That's very
Getting
good.
on the bouncy ball.
Bouncy ball, yeah. And another
then
one.
the sacral massage.
Yeah. Oh, yeah. Sacral. That's counter pressure on the sacrum. Yeah, because baby could be in an OP position in the early labor, in that first phase of the first stage of labor. The baby has his head up. He needs to put his head down. And so anyway, she has a lot of back labor. And so you can do that sacral counter pressure. Oh, that's always a good one. I'm thinking another one too. We always have a rocker in the room and she can rock. Okay, pelvic rocking is very relaxing. You can try it right now. Just rock back and forth and you can see how much it can relax you. Okay, so you want to make sure that you're well versed on non-pharmacological methods. What's an epidural?
Pharmacological.
Yeah, because it involves medication, some good medication, right? And we're going to numb her from the waist down for labor. Okay. And we'll go over that a little bit more. How about a spinal? That's quick, right?
C-section.
Yeah, that we can use those for C-sections, right? Go right into the spine. Usually we do that in the OR and they inject, boom, patient goes right down. We put them on a left lateral tilt. And then basically do our C-section. So it does really well. Okay, and we're going to go over. Now the pudendal block, you're doing it during the second stage when she's pushing, and you're just numbing up those pudendal nerves. Okay, good. So that's for a woman in labor. All right, so now she's delivered the baby. So how are you going to help her adapt to her new role with the baby? What do you
Teach
promote?
her, you can teach her breastfeeding methods. You could teach her
Skin to skin.
how to bond with the baby,
Bonding.
Yeah,
different
skin to skin, right?
reflexes.
Yeah, skin to skin, come out. You can do, I can tell you guys, you can do your Apgar score while baby's on mom's chest. Believe me, I've done it many times. And of course, I always have my nice warm little receiving blanket because those babies come out and they are wet. And so I don't want to cold stress my baby. You never want to cold stress a baby. Keep the baby warm and do your Apgar score. All right. So remember, on the Apgar score, we're looking at what? We're looking at, you tell me,
Oh, wait a minute.
heart rate, right? What else?
Appearance.
Mm-hmm.
Grimace.
Respiratory.
Hospital tone.
Yeah, you got it. So if this baby comes out and he's got an Apgar score of 7 to 10, because you're going to rate it from 0 to 2. If he doesn't have any color, nothing at all, he's pale could be, it's 0, right? But if he has a trunk, the trunk is pink and his little hands and feet are blue, what is that called?
Acrocyanosis.
Acrocyanosis. And I'm going to give him a 1 for that. He deserves some credit for that. And then if he's all pink, usually at 5 minutes on a real healthy baby, you can have the peripherals or his hands and feet will be pink too. And then you can give him a 2. So that's how we rate them. So on every area that you stated, you're going to give a score of 0 to 2. All right. So what you have to remember, because a lot of times on HESI, and they do have a question on Apgar. I'm going to tell you, they always have a question on Apgar. What they do is they give you like the scenario, and then based on what's in that scenario, you have to figure out, the scoring. So that's why you have to know the scoring. And if you have a score of 7 to 10, that's good. He only needs, be dried off. Okay. Yeah. He's got a heart rate. He's got muscle tone, and he's probably off for his color, and maybe he's a little sleepy, but that's about all. 7 to 10 is a good score. Now, 4 to 6, he needs a moderate amount of resuscitation. Okay. He may be a little bit sluggish, coming out. Maybe mom got a drug, which we should not do when she was in transition phase. And so he's a little sluggish. He needs a little bit more stimulation. What should I have on hand for that kind of baby if you gave a drug, say during the transition phase of the first stage of labor? What should you have on hand?
Narcan.
Narcan.
Narcan. Good. Yeah, I always have that close at hand. And then 0 to 3, he needs a lot of help. That's a very bad score, because you're thinking of what you're scoring, and he needs a lot of resuscitation. And then you have your NICU team in there. You have your NICU nurse, and then you have your RT, respiratory therapy, in there too. Okay, so I put in here, what happens when a newborn experiences respiratory distress? What do you see?
Grunting.
Grunting.
Use of stomach muscles.
Okay. So
Nose flare.
You got retractions, right? What do you got here? Tachypnea. He's breathing really hard, right? Very fast, right? Greater than 60. Well, what's the normal respiration rate for a newborn?
30 to 60.
Good, 30 to 60. So he's tachypnea. He's really breathing fast. His color doesn't look, guys, it's dusky, grunting. And what about nasal flaring?
Mm-hmm.
That's never good. So those are really important to basically go over if you need to. How about grief and loss? Okay, we know in maternity, we like to promote, oh yeah, this is a really happy place, but we also have our times that we have grave sadness, and when we have like a stillborn. So how should that nurse that's in that room with that patient talk to the patient who just had a stillborn?
Ask if they would like to hold the baby.
Yeah, would you like to hold the baby? So, you're going to develop a keen sense of trust with the patient. And we always try to keep one nurse in the room with that patient, and she could be in and out, but we try not to have different nurses going in and out of the room. Okay. And we keep it a very quiet room, right? And do you want to hold your baby after it's born? Do you want to, some women have opted not even to look at the baby. That's okay. But meanwhile, you're using your therapeutic communication and you're always going to make eye contact. And a lot of times I'll sit down in a chair so I can be level with my patient so that, she knows I care. By you maintaining eye contact, the patients know that you care. And then, touch is always nice, but only if it's okay with the patient. Okay. So you always want to ask your patient, would it be okay if I touch your shoulder just to kind of give you a reassuring, and they'll let you yes or no. And then you want to create a memento box. Now, this is a really nice box. At the hospital I work at, we have a really nice memento box, and we have a little white rose on the top. And we'll put everything, like if she wants a picture, we take pictures. If the baby comes out and the baby has maybe a sunken head and maybe there's a little problem with one side of the head, we'll go ahead and make sure we get the cap on before mom sees the baby, and make sure that when we take the picture, we get the good side of the baby. And sometimes you have a little lock of hair. We ask the mom what she would like to put in the box, and they'll let you know. All right. So,
Miss Dunham,
yes.
Jessica Metz just texted me and said that her Wi-Fi just went out, but she's headed to the library to get back on.
Okay. All right. So what was her last name?
Metz?
Metz, M-E-T-Z?
Yes.
Okay, let me write that name down. So when we do attendance, I can keep that track of things like that. Okay, good. All righty, got it. Okay, so now we're going to look at the physiological integrity, and we may have questions about giving medications. Like, they want to know, does the nurse recognize the side effects of the medication? Like I talked about what can happen when you're giving magnesium sulfate. All right. So that can take down the deep tendon reflexes. That's actually the first sign that you got too much magnesium going, is when you check her reflexes and she doesn't have any. That's not, it's a scary thing to happen. I'm going to be honest with you. You got a bag, and so you already gave her for like 4 grams of a loading dose of magnesium sulfate. And so I may ask one of you, and I say, I'm working really feverishly in this room. And I'll say, hey, can Clarencia, can you please do the deep tendon reflexes on my patient? Okay. And so Clarencia will go in there and she'll assess the DTRs. When you lose DTRs, you're getting into a range of too much magnesium. So then you call the doctor, and you probably get an order for magnesium sulfate level, okay? And then you can base and titrate your medication, based on that level. I always have calcium and gluconate, remember that, okay? Now, another drug that you want to know about that could be contraindicated is methogen. Methogen is a great urine tonic drug. We use that especially when you have uterine atony, but because methogen increases the heart rate, you want to be careful with methogen. You don't give that to a hypertensive patient. Okay, so those are things that you probably, when you look at different drugs, you probably want to take that into consideration. So these are the following drugs that I have found to be on HESI before: magnesium sulfate, Pitocin, which is your synthetic version of oxytocin, carbopress, and hemabate, okay, and methogen. All right, yeah. And Sandra's book has a really good chapter on maternity drugs. Okay. Now, there could be a question on monitoring results of maternal and fetal tests. Maybe just a basic non-stress test. Okay, we do that for fetal surveillance. We want to make sure, how's this baby doing? Okay, we're looking for the well-being of the fetus with a non-stress test. And it's a really simple test. It's not an invasive test. That means that all we have to do is put the monitor on her. We put the toco on the fundus of the uterus, and then you have the ultrasound electronic for her heart rate, for the baby's heart rate. Okay, and what we're looking for is for acceleration of the fetal heart rate with fetal movement. Easy test. It tells you a lot about it. Okay, and so now I'm going to move into some complications. So a big part of HESI does cover postpartum complications. So I'm going to go over those today with you because we have seen that on past HESI tests. So postpartum complications. So you know about postpartum hemorrhage and hypovolemic shock. How about a thromboembolic disorder? Right? They can throw a clot really easy. Puerperal infections. Another term is postpartum infections. Things can happen, such as big on HESI, chorioamnionitis. Big on HESI. And then you have subinvolution. Remember, these are postpartum complications. So involution is a normal process, right? Involution is how the uterus will go back down, will invert, go involute, go descend, and go back down into the pelvis to where she was before she got pregnant, correct? But subinvolution is there's a delay in that process. So you have to get in there and you got to figure out what is causing that. A lot of times is that retained placenta fragments. That's why when that placenta comes out, and LPNs can be in the delivery room helping out, and I would probably say, Nurse Ivy, would you look at the placenta for me? And I would ask him, look at the maternal side. What side is that, Nurse Ivy?
The dirty Duncan.
The dirty side.
Yeah, a dirty side. That's cool. Nurse Patel did very well. The dirty Duncan. Yeah, that's the maternal side. And that side we look at very carefully because it has like these lobes, okay? And it's easy for one of those pieces of the placenta to stick to the endometrium. Very easy. And so that's why we look at that, and you have to really look at it and make sure there's no pieces missing. And now I flip it over and I tell you to look at the neonate side. What is that called?
That's the queen side.
Shiny Schultz.
Shiny Schultz, right? And I say it like shiny Schultz because it looks like the neo side is so pretty. It is shiny and it's new. It's the neonate. It's new. It's for him, and that's where the cord actually is in the middle of the placenta. So that kind of gives you a clue too. But again, you want to make sure that everything comes out of that on the placenta. Now we're going to talk about mood disorders. We're going to go over postpartum blues, which then can go into depression if it gets more intense and it gets more complicated. That depression can show its face in like 4 to 6 weeks after delivery. It's not good. So we want to help. So we want to make sure that our discharge planning that mom has some support. We don't want to discharge anybody home without support. We're trying to prevent. As you can probably see, we want to prevent these complications from happening. That's what nursing is all about, okay? By preventing a postpartum infection, make sure that you have sterile gloves when you're doing a sterile procedure. Like when you're putting a Foley catheter, make sure that you're following sterile procedures, okay? If you're checking your patient during labor, make sure that you got a sterile glove, okay? And that you're very careful when you go in, that you don't push any kind of bacteria up in that uterus, because we do not want her to have chorioamnionitis. All righty. So let's start out with shock. Okay. So there's 4 different types of shock, right? You have the cardiogenic, where she can throw a PE, pulmonary embolism, or she'd be anemic, which a lot of women are, and they lose a lot of blood at birth. Now, if you have a vaginal delivery and you lose greater than 500 mLs of blood, you got you got a hemorrhage. Okay, she's lost a lot of blood. So when I think about mLs, I'm thinking about these big amounts, 500. I usually equate that to like an IV bag. That gives me like a visual, and I can say, well, 500. Well, that's a lot of blood. Okay. And then, of course, hypertension. If you got a preeclamptic patient, you have to be careful of this too. Now, hypovolemia, it just means that she has a low volume, right? And that could be, she has lost a lot of blood. Okay. Again, for vaginal delivery, greater than 500 mLs is a hemorrhage, and for C-section, greater than 1,000 mLs, it's a hemorrhage. But these are a lot of blood. Okay. Now, anaphylactic, you have an allergic response, and of course, septic is caused by that infection. And we don't want her to have any of those. Okay, so we have hemorrhage. So we divided it between early and late. And all that means is early, it just means it happens within 24 hours postpartum. Okay, that's the first go around. And you can see a lot of postpartum hemorrhages during the early parts of that because the culprit could be retained placenta. And we want to get in there and get it out so that she doesn't hemorrhage. Now, late, the term that's between 24 hours and 6 weeks postpartum. And yes, she can go home and start bleeding. That's why part of your discharge teaching for a patient going home, you teach her the difference, of the lochia, her drainage she may have. So that's lochia. And lochia rubra is usually the first 3 days, okay? Then after that, it goes to lochia serosa. And that's more pinkish because now you got more mucus and you have less bleeding, all right? And then you have lochia alba for the rest of the 6 weeks, all right? And that's really has a lot of WBCs in it, has a lot of mucus in it, and that's what we call it alba. Now, the main thing when you're teaching your patient about that is because when she goes home, and so she says, oh, look, my discharge has changed colors to more of a pinkish. That's what the nurse told me. Okay. Now, a couple days later, she wakes up and there's blood, bright red bleeding blood on her bed. Okay. And she knows, oh, that's right. The nurse told me if I saw that, I need to call and get back to the hospital. And that's because she started to bleed again, go from serosa back to rubra, which is never good. Never, never good. So that could be that we get her in, we tell her don't eat or drink anything because we're thinking ahead that maybe we have to do a curettage, get rid of that, clean out the uterus, because it could be that that little piece up there decided it was trying to come out, and that's why it started to bleed again. Okay, and then you have some major risks, such as hypovolemic shock. What happens is that you have an interruption in blood flowing to the body cells. Every cell in your body, every organ in your body needs oxygen, okay? And so blood carries oxygen throughout all your cells, all your organs. And so you want to make sure that these things keep flowing, okay? And when you have a diminution in blood flow, you can go into shock. All right. Now, your signs and symptoms associated with that, the first one you see, guys, is tachycardia, the first one you see. And that's really significant because after delivery, okay, your patient usually would have a slower heart rate, okay? And so now you come on and you assess her and you take her heart rate, and she's got a heart rate now of 120, and you go, oh, that's not normal. So now you've got to start looking, because the next step is her blood pressure is going to fall. And then your patient's going to get symptomatic. She's going to be pale, cold, clammy. They don't feel good, okay? And they have, if they get really bad, they have LOC changes, level of conscience changes. And then the kidney knows it's not going to be getting the blood it needs, because the blood's going to the heart and the lungs, right, to keep it going, keep the patient alive. So then you have decreased urine going to the kidneys. So then you have a decreased urinary output. It kind of makes sense because every organ needs blood. All right, so if I ask you a question, the first sign of hypovolemic shock is most often what?
Tachycardia.
Tachycardia. You got it. Okay. Okay, again, I just went over that. You know, what happens when hypovolemic shock occurs when the volume of blood is depleted. And you just cannot fill the circulatory system. It's just not there. And if you don't act pretty quick, guys, your patient can die. Okay. So I put another slide in here, and I got Mr. Help here. He's got a sad face here. He goes, "Help, I need help." And this is exactly what I just went over. Tachycardia, the blood pressure is going to go down. It's going to get pale, cold and clammy skin, LOC changes, mental status, and decreased urine. Okay. So what are we going to do? How are you going to correct this? Well, got to stop the blood loss. Got to find out. Check the fundus. Is her fundus soft? What kind of bleeding is she? Is she having a lot of blood, or is she having a trickle of blood? Because a trickle of blood can be from a laceration higher up, you know? May you have an IV line? You probably have an 18 gauge in, because you can give IV fluids faster with 18 gauge, and you can give, of course, blood transfusion, because you need to replace those lost erythrocytes. And you want to give oxygen, because you have a pulse oximeter on her, right? Okay, you got the picture? You got your poor lady in the bed here. She's scared as anything. And then you want to put a catheter in, because, again, remember, the kidneys will start to shut down, and you have to get a good INO on what's going in and out. Okay, you want to make sure the kidneys get corrected. So those are ways to correct hypovolemia, and they happen very quickly. Okay, very quickly. And of course, you know, a lot of times you're seeing this happen. We call it a code. It's a code on the OB floor. It's called PPH code. And we usually say PPH room 2, and that means postpartum hemorrhage room 2. And that the team comes in, and everybody takes a role. Everybody takes a role, and we get this going very quickly. Meanwhile, you got family in that room. Okay, so meanwhile, you got to keep the patient calm, because she's scared to death, because she's not feeling well and she's bleeding. She can feel it. And then you got family members, and you got the baby. So that's why it has that team, that one of the nurses will take care of the family and get the family out of the room, so you can take care of things. All right. So we have these postpartum hemorrhage. You have early signs, uterine atony, when you know there's boggy, uncontracted uterus. We talked about a laceration. Now, laceration is a steady trickle of blood that comes down. It could be higher up in the vagina. It could be that maybe she got a little torn during the delivery. You know, those macrosomic babies, big babies, can really tear mom up inside. Then you may have a hematoma in the vulva, and it's very, very painful. And they're big and they're bluish, and I have a good picture of them. And then you may have a large gush of blood from the vagina. When I see that, I'm thinking, okay, let me check that fundus. And then saturation of more than one peri-pad in 15 minutes to an hour. And of course, you got your tachycardia. So here, I got the 4 T's for you. So you got your tone, okay, which is your uterine atony, your tissue, which is your retained placenta fragments, trauma, which is your lacerations, and a throbbing, which is your coagulation. I want to know what her factors are. All right, so I have here for you, I went over blood loss already, and I have here the uterine atony. This is why HESI puts it on there, because it is a leading cause of early postpartum hemorrhage, okay? So I always want her uterus to have good tone. So I'm going to massage the fundus. You're going to prevent a bladder distension. Now, when you know from your anatomy that the bladder lays right underneath the uterus. Okay, when the bladder is full, it will push that uterus up. And a lot of times it pushes it up and over to the side. So I don't want that to happen. So I want to make sure that I check on the bladder, make sure that it doesn't get distended, because we get a lot of fluids, okay? And so as nurses, we can like offer the bedpan, okay? And you want to assess how she's doing. I mean, if she had an epidural, she may not be able to void, so you may have to straight cath, but you've got to make sure that that bladder is not distended, okay? And then, of course, fundal displacement, I'm talking about that. I want to talk about the bladder being huge. Okay, these are your medications. So you got Pitocin, you got Methogen, Hemabate, Misoprostol, and I told you Carbopress. These are drugs that I definitely, you know, look them up. You had them through your lectures, so look at those, okay? A retained placenta, all right? Lacerations and hematomas we talked about. Inversion. What's an inversion of the uterus? What happens with that?
It's sucked back in.
Yeah, inversion, actually what? It comes out, right? All right. So it's a weakness. And so all of a sudden you see this inversion of coming out after delivery. And I tell you, I have had a couple patients that the whole uterus came out after delivery. And it is another obstetrical emergency where a lot of times we have to put the patient under general or give her a good relaxant so we can try to push the uterus back up. Okay. And then you have subinvolution. These are all causes of this hemorrhage. All righty. I think we talked about this a lot, and I think you got that pretty down pat. Okay. So let me ask you a question. Which medication will the nurse anticipate prescribing to control postpartum uterine atony?
Methogen.
Yeah, you bet. Good. What is betamethasone?
Is that a steroid?
Steroid.
Yeah, that's a steroid. Yeah. And why do we give betamethasone to a pregnant woman?
For baby surfactant.
Infection.
To increase the production of surfactant before, especially for a preemie baby, right? Yeah, we're going to give that surfactant because surfactant is not produced in utero till almost what, week 27, I think it is. And so basically we want to give it to a preemie baby, and it's because they won't have enough surfactant. So we'll give this to mom, give it in 2 doses, 24 hours apart. All righty, good. All right. So the nurse, you assess a postpartum client and you notice uterine atony. Which nursing action, which action should the nurse perform first?
Fundal
Fundal massage.
You better believe it. Good. Oh, this one is easy. See how easy this is getting? So what is the nursing action that's appropriate in the care of postpartum patient to prevent fundal displacement?
Two.
Good. And see on this, I want you to take note. Read the question. Because you're going to think, oh, there it is, perform a massage. No, read the question. We're preventing fundal displacement. Good. All right, the nurse is monitoring a client in the immediate postpartum period for signs of hemorrhage. So which sign, if noted, would be an early sign of excessive blood loss?
2.
To the increase.
Increase. That's right.
Well, you like
Everybody got that?
Mhm.
Okay, good. The postpartum nurse is caring for a woman who just delivered a healthy newborn. The nurse should be most concerned about the presence of subinvolution if which occurs.
Two.
Good. All right, so remember something. If you got uterine without tone, remember, massage the fundus, put a Foley in, right? And you're giving Pitocin. And if she doesn't respond to the Pitocin, the next drug would be Methogen. Good. On assessment of a postpartum client, the nurse knows the uterus feels soft and boggy. Oh my goodness, I know you know this. The nurse should take which of the Good, thank you. Okay, so I want to show you a picture here. Excuse me, of a hematoma. This is what they look like in the vulva. Now, this is very painful. So so if I have a lady that had an episiotomy, what should I do for the first 24 hours?
ice pack.
Ice pack. Get the swelling down, because we don't want any kind of this kind of collection of blood in that area. Now it's very, very painful. Oh my gosh. Okay, so we're gonna apply ice packs to the perineum for the first 24 hours. And then after that, you could, introduce her to the sitz bath, and she'd be very happy to get on the sitz bath. and have some nice warm water to flow over. Yeah, you gotta be very careful because you can have lacerations of the cervix, the vagina, the perineum. You know, when you have a traumatic delivery, okay, for instance, you can create lacerations, all right? And if you have an if you have to use an assisted device, such as forceps or vacuum extractor, that can also create lacerations and can also create a hematoma, all right? Because those things are, you know, forceps are stainless steel. You know, they don't move. They go in and they click on, you know, and then they use those to help assist pull the baby in, all right? And then this tissue down the vulva area, the perineum, is very, very soft tissue. And so it can bleed easier and it's a very vascular area. Okay. If she has a 4th degree or 3rd degree, you have to prevent constipation, okay? Because you're getting down into what? The rectum, right? So here's a picture of that here. See, here's your 3rd degree, and you're going down, you're going all the way through the perineum and the different muscle tissue, and then you got here, you're going into the anal sphincter, okay? Yeah. Now this is a midline, all right? Now here you got a 4th degree, and a 4th degree, you're going into what? The rectum. See here? And it gets, and they can get fistulas in here too. And boy, that happens, you're in big trouble. So we want to make sure we apply ice pack. We want to make sure we prevent a constipation. Okay. So what kind of a diet do you think this kind of patient would be on?
High fiber.
High fiber, yeah. High fiber, you know, and make sure they drink a lot of fluids, right? Yeah, make sure, and probably give her some, maybe some Colace, you know, make the stool softer, because psychologically, these patients are scared to death about having their first bowel movement after delivery. And you can see why, okay? All right, and then we talked about a hematoma, and it's just, you know, Oxycontin, let me see, Percocet, you know, all those kind of really good opiate drugs, they don't really help too much, okay? So, you know, ice pack and good cis bath would be the whole thing. And make sure she doesn't push down when she has a bowel movement. Okay. And we talked about inversion of the uterus, all right? You know, this can happen. We used to do a lot of fundal pressure, you know, especially with these babies, these big babies, and we have to get on top of the patient and kind of put our elbows on and really press down on the fundus, okay? Well, that can really put a lot of pressure on that uterus, and that uterus could come out very, very easily. So we got away from doing a lot of fundal pressure. And then too, if these providers, if they don't want to wait for the placenta to come out, they'll put excessive traction on the cord. You don't do that because a cord can snap off. All right. And when they snap off, then the placenta's in there. Remember, the placenta is embedded right in the uterus, in the upper portion of the uterus on the posterior wall. Now, she had the baby. So now what? Stage 3 is expulsion of the what? Placenta. I mean, stage 3, yeah, the placenta. So you don't want to put a lot of traction on the cord, because, you know, you have to, that has to break away from the endometrium. All right. Has to break away from the endometrium. All right. And we already talked about subinvolution. So we're going to just move on here. Let me, I made that bigger for you. Here we go. Okay. So remember your postpartum assessment, that bubble HE. So we on the HE is H is the Holman sign, right? So classic symptoms of a deep vein thrombosis includes what? Muscle pain, positive Holman sign, and swelling your affected limb. Is that true or false?
True.
True.
I gave that kind of away. All right, good. Okay, the nurse is monitoring a postpartum client who is bleeding for signs of shock. So which indicates an early sign of shock?
Who?
2. You got it. Okay, good. Okay. All right, we'll do this, and then I think we'll take a fast break at 4 o'clock. Okay. So this infections. Now, infections unfortunately can happen. And so we want to always use standard precautions, right? To help prevent the spread of infection. You don't want that. And so you want to make sure either she had a miscarriage or induced abortion or, a birth, you want to make sure that she doesn't get that. But if she starts having a temperature of 100.4, that needs to be noted, right? And then if she has like 2 days after the first 24 hours, you got a problem going on. Now your patient, and this is for any patient, med-surg patient, you want to always look for signs and symptoms of an infection, which you have the fever, 100.4 or greater, and your patient's going to feel, what? Lethargic. Isn't she going to feel icky, right? Tired? She doesn't want to eat. You probably don't want to breastfeed. And so, she's going to basically, feel like she got flu-like symptom. Now, endometritis. This is a very common one. And what happens, remember, inside the uterus is called the endometrium, right? So what's happening is that you have this infection in the lining of the uterus, all right? And so what gives it away is she's got abdominal tenderness, she's got pelvic discomfort, and the main thing is, guys, she's got a foul-smelling discharge. That tells you that inside that uterus, something's not right. Okay. And so what happens, that placenta site I told you about, and where the placenta comes off in the endometrium, that's an open area, like a wound, like an open wound. And that can get infected, all right, very easily if you've got bacteria that's traveling up. So that's why you want to make sure that whatever you do, you're using what? Sterile technique when you're going inside anymore, all right? So where the endometritis can start is at that placenta site because it's wide open. And that's why you want her uterus to contract, is because you're putting pressure on that placenta site. Okay. And then she's going to be on antibiotics. And we always give, when we open somebody for like a C-section, when you have a surgery, you're going to give them prophylactically, you're going to give them some antibiotics. It helps combat any kind of bacteria that may be in there. Now, another very common one is cystitis, urinary tract infections. And you want to get that one is cystitis. You don't want it to go into polynephritis, where it goes higher and affects your kidneys. So I'm going to teach her how to clean herself after having a baby, the good peritoneal care. And so you get the little squirt bottle, the squirt bottle, you put some warm water in it. And every time either she urinates or has a bowel movement, she's going to take the squirt bottle and she's going to clean off. Then she takes a little toilet paper and just pat dries it, right? Pat dries it. Okay. And doesn't, uses it once, throw it in the toilet. And if she needs another one, pat dries it, right? And she always goes from what? The front to the back. Never go from the back to the front. Okay. And then you want her to have, more fluids, especially if she's got a cystitis going on. So you got to be careful. Again, urinary tract infections can happen very easily with a woman. A wound infection, it can happen with a C-section, a patient who has a laceration or an episiotomy, she can have a wound infection. So when you're looking at the episiotomy, you're going to evaluate it, okay? And so you're looking, remember REDA, R-E-E-D-A, I put it here for you, okay? You're looking at redness, you're looking at edema, ecchymosis, which is your bruising, and your discharge or your drainage, okay? You don't want any drainage coming out of an episiotomy. And then approximation is approximation of the suture line. And when you're sewing somebody up, you want to make sure that your skin approximates to the other side. Like I have my hands here. So I have one hand here and I'm approximating to my other hand. You want that suture line to be just right. Just don't forget, she's going to have a life after all this, all right? So you want her not to feel subconsciousness about her episiotomy site. Now, mastitis. This is a picture of mastitis, which is the breast is very heavy, and it's very hot to touch and very sore. And so they don't feel good. They feel like they have flu-like symptoms. And when they get infected, they can actually have purulent drainage. Okay, so we're going to put her on the antibiotics. We're going to put warm compresses. She's going to have to pump and dump her milk if you got purulent drainage, because you don't want to give that to the infant. Just a support bra, nothing really tight, just a support bra because the breast is heavy. All right. And then of course, hydration and analgesics. Oh yeah. Analgesics and sometimes antipyretics in order to keep down the temperature, because these women can get high fever. Okay, it's 4:02. I'm gonna give you a 10-minute break. Okay, and then we'll come back and resume. So 10 minutes, take 10 minutes, stand up a minute, get something to drink, and be back. Okay. Okay, thanks guys. Hi, Jessica. Did you have a question?
Um,
Hi.
Hi, sorry. No, I didn't have a question. I had to run to the library because our internet went out.
Okay. All righty.
So I'm just sitting on here. I don't have anywhere to go.
Okay, your little box was lit. So when I see the box lit, I thought maybe you needed something. Okay.
Oh, no. But did someone tell you so
Yeah.
you know how much time I was actually gone?
Yeah. About how much time were you gone?
I mean, I just lived down the street, so it took me 5 minutes to get here.
Oh my goodness. So I'll say about 10 minutes, huh? 10, 15 minutes. Good.
8? It's less
I
than
love
that.
it. I love it. You're gonna be a great nurse. You're right on target. I love it.
Great. Yeah.
Good girl. Good. Okay. Thank you. I'll tell your professor.
Okay. Thanks.
You're welcome.
Miss Dunham, did you take attendance already?
It's on now. Zoom, takes everybody's name.
Oh, okay.
It does it automatic, and it actually puts the time that you're on there.
Oh, okay. Well, I was on here.
And what I have to do tonight, it'll take me a couple hours, is separate everybody out.
Thank
But
you.
yeah, it comes automatically with the Zoom. That's why I love it. Zoom records everybody. Yeah. Did you have any questions, Lauren, about anything so far?
No, not at the time. It's been kind of clicking for me the whole term.
Good.
And I
Good.
enjoyed the class.
Good. You have to go on and then work in labor and delivery one day.
Yeah, that'd be cool.
Maybe, right? Yeah.
Yeah.
Yeah. That's what I did
Yeah.
and enjoyed every minute of it. I still do.
You still work in maternity?
Yeah. Yep. Still working. But I love it. When you love something, you never go to work. You realize that, right?
Yep.
When you love what you do, you never go to work. That's the same. So you really want to enjoy what you do. So whatever area of nursing you like to go into, you want to be sure that you love it. Yeah. And your life goes by. Wham, it goes by.
Yeah. Yeah, I'm looking into getting into like the OR.
Okay. Yeah, I like the OR. Yeah. You don't have too much interaction.
No.
If you're a people person,
Yeah.
the OR is not the place because your patient goes to sleep.
Yeah.
They go to sleep pretty quick. And then you
Yeah.
hope and pray they wake up from that
Yeah, they don't complain
anesthesia.
that much.
I've seen patients not wake up from anesthesia. And then we had to intubate them and take them to ICU where they had to bring them out slowly. Yeah. Yeah.
Yeah, I work in the ICU. We
Okay.
kind of see that happen a lot.
Okay. Yeah, you do. That's why nurses, we make really bad patients. Because we see a little bit, we know a little bit too much, seeing a little bit too much.
Yeah.
And so we go, oh, I want to make sure I come out of this anesthesia. Right, good. Okay, so you work in ICU now?
Yeah, I work at CV ICU. Yeah, so most
That's
of our patients they don't go to PACU. They recover on our unit, and then they kind of wake them up or kind of keep them stable if they are having trouble with the anesthesia. So.
okay. Interesting. Well, that's a good background you have.
Yeah.
Yeah, that's good. It's always good to do that kind of work when you're going through school, because then you can really understand it a lot more.
Mm-hmm. Yeah. It
Yeah.
made a difference. It definitely made a difference.
Yeah, it does. Now it's not easy, you know, when you're going to working and going to school, but
No.
no.
The
Okay,
world-
everybody. Everybody's up. I think that's been 10 minutes. I want to not lose some time here. So yeah, it's 4:11. Alrighty. Got some more questions to ask you, and you're all doing very well. Make sure you get in there and answer. And if you don't know the answer, then write down the concept so that you can go back over and open that and open your book, your HESI book. Okay. All right. Come on, everybody. I'm going to go on now. I don't want to waste any time. We got a lot more to go. Let's see where I'm up to here. Okay, so how about this question? All right, let's just get rid of this. Okay, your nurse is caring for a 4-1-day postpartum client. For 4-1-day postpartum client. So which client assessment requires the need for a follow-up? Oh, this was a good one. So you have 4 patients. Okay.
Or because the client might have infection.
Yeah, what infection is that? Has a foul-smelling odor.
Endometriosis.
Yeah, good. Love it. What about this one? The nurse is monitoring a postpartum client who is at risk for developing postpartum endometriosis. Oh, you know this one. Which finding, if noted during the first 24 hours after delivery, supports the diagnosis of postpartum endometriosis? 3.
3.
Well, would she have is that a high temperature?
I would
Is
say
it-
1.
1.
1. Good. Okay, you got it. Okay. See how we broke that down for you? Yeah. All right, I got that. Okay. So we're going to talk a little bit about thrombus, PE, you know, DVTs. So a lot of things we see in postpartum, all right, is a DVT, deep vein thrombosis. And everybody knows what that is. What are your common symptoms of a DVT?
Pain, dyspnea, whatever.
Okay, they have pain, right? And how
Redness,
do you know it?
heat.
Yeah, they have heat. Okay, it gets redness, red. The calf can be a lot red. And what happens when it goes to the lungs? It becomes a pulmonary artery. Then you can have your dyspnea and chest pain, right? Tachycardia, tachypnea. Okay, good. Okay, and we'll probably give anticoagulant IV heparin. Okay, but what you gotta know for probably HESI is that Holman sign. Okay, the Holman sign, because that can happen. Now, years ago we had more of that than we have today, because years ago we used to put our patients up in those hanging stirrups for delivery. Not a good thing. Okay, and so they came back to postpartum with a lot more pain in their caps, and then we revamped those beds. We don't put them up in stirrups anymore. We put them on the foot pedals, and we decrease this quite a bit. But anytime you're going to work with a patient and you're going to prevent a DVT, what should you do? What should you encourage?
Ambulation.
Yeah, early ambulation to prevent. Good. Okay. So the nurse is developing a plan of care for a client recovering from a cesarean delivery. Which action should the nurse encourage the client to do to prevent the thrombophlebitis? Okay.
3.
Yeah, you got it. That was too easy. All right. I hope HESI's that easy. Okay. Postpartum blues. Okay, this is the moods we talked about. You got the postpartum blues with your baby blues. Okay. Now, this one, she just feels, very overwhelmed. Okay, they have difficulty sleeping, some fatigue, and their emotions are like up and down. Okay, but they continue to bond with the baby. They continue to take care of their baby. Now, usually it peaks around the 5th day and goes away by the 10th day. Okay, and it usually doesn't impair function. Usually if you give the mommy support and she's able to maybe eat a dinner or take a shower, feel better about herself, that really does help. But now here you're going to go into more of a postpartum depression. So usually this one will last a lot longer than 10 days. Okay. It lasts more than 2 weeks. And they have intense and pervasive sadness. Okay. So they have severe labile mood swings. They're really all over the place. And insomnia, loss of appetite, and they have a thought. They're not going to do it. They have a thought of self-harm. Now, really, it disappears without help. Now, and they need help. They have to have help. Okay. And they have a lack of interest in their newborn. So is depression a little bit more than baby blues? Yeah, it is, because they need help and they're going to have to go through some kind of psychotherapy and antidepressants. Now, we have seen postpartum psychosis, okay, and it is real, and it does occur a lot to do with bipolar disorder. So in that first OB visit we talked about, where they come in and you get their history, you do their graviton, GTPAL, that kind of visit. You want to know if they have any kind of psychological disorders, okay? Because that would give me like heads up. Okay, so I'm going to get it through the pregnancy, and then after the pregnancy, I have a heads up on that one. Okay, what they do is they hear hallucinations, they hear their voices, and it tells them, they're not worthy of the baby, or the baby is not normal, and you want to get rid of the baby. So you have to be very careful with this kind of patient, because they can kill the baby and kill themselves. So this is why it's very, very, very cautious. So this kind of patient would be on a psychiatrist. They would have antipsychotic and mood stabilizers. Okay. All right. Usually in HESI, don't see too much. I'll look on my review list here to see if they do it. Okay, so now we're going to move to newborn. Now you just kind of had all this in your lecture, right? So we have newborn reflexes. When you're looking at reflexes, you're looking at their neurological function of these babies. All right. So you want to make sure that they have a good suck, they want to make sure they have a good gag reflex. Their eyes close. And you look for these different. So up in the corner here, this one's called rooting. And basically it shows the baby where what go, right, for food. Okay, they have to, do you need food to survive? Yes, so that's a survival. That is a survival reflex. Okay, they need to have that. This next one is what? Sucking reflex, right? The sucking reflex. And so, babies that have cleft palate and cleft lip, they don't have this ability because they can't get a negative pressure. So that'd be something. So they have a hard time with nutrition. All right. And then you got your tonic neck reflex. This looks like a fence here, called fencing. And then this one here is the stepping reflex. What happens is that they touch a cold surface, whoop, and they come back up. So here this little baby looks like he's dancing. You can also call the dancing reflex. Over on this side, you have the Moro reflex, or another name for it is called the startle reflex. So when the baby senses some kind of danger, they're going to open their arms. You can see too that their little fingers, they kind of form right here. You can see they form like a little C. All right, let me get rid of this here. And then the next one is the palmar grasp reflex. All right, and so you want to make sure that this is good, because a lot of times if you have a traumatic delivery, sometimes this grasp reflex could be weak. All right, because that means that there was some damage to the nerves of the arm. All right. So these are pretty important reflexes that you assess for. And then you got again, the plantar grasp reflex, okay? And so you want to make sure that, basically you can see here, there's put a finger right there, and he kind of curls his toes around that one. All righty. So we're
I have
gonna
a question.
Yeah, go ahead, sure.
I know normally with like the cleft palate, you'll see the baby with the cleft lip, but are there circumstances where the baby just has the cleft lip and not the cleft palate?
Yeah, it can happen. It's just how the neural tube closed at that time that happens during embryonic stage.
So there can be one without the other in both scenarios?
They could. I mean, usually you see them together, but you could. That's why we always check. Even with a normal mouth on a baby, we'll check we'll check inside the mouth to make sure that everything has fused together.
Okay,
Now,
just wanted to check.
Oh, sure. Now your Babinski reflex. Now HESI likes your Babinski reflex, and the Babinski reflex, you stroke the side of the foot and his little toes. You can see here that kind of fans out. Okay. Again, when you're looking at reflexes, you're looking at how the baby neurological system is working. Now, HESI does like some reflexes. And from past HESIs, they like the gagging reflex because it can. These are reflexes that helps keeps the baby alive. All right. So like blinking for the eyes, we talked about sneezing, get the fluid out of them. Babies are born with a lot of fluid. All right. So by sneezing, having that reflex, they feel like fluid comes up and they can sneeze and get it out. A gagging reflex is very important to survival of the baby, helps keep them alive. We talked about that. Sucking, again, nutrition, very important, and grasping. Okay. So we also talked already about the moral reflex, the rooting, and Babinski. They always like the Babinski reflex also. Okay. So if I ask you a question, which of the following describes the Babinski reflex? A. Good. Okay. All righty. The first bath, they have the little cord still hanging on there. You're not going to put them into a submersion of a bath, right? So you can do a little sponge bath until the cord actually falls off. Do you pull the cord off?
No.
No. Thank you. I just want to see if you're awake. I think you are. Okay. And I'm going to tell you, we always wash the head last. What do you think we do the rest of the body and do his head last? Why do you think that?
Probably to keep
Where
the
they lose most of their heat.
Thermoregulation.
regulation.
Yeah, somebody said my favorite word, thermoregulation, because they lose a lot of heat through their head. Good. Everything's coming to play. See how it all comes together? Okay. All right. How about GI? Their stomachs are really small. Okay, so you don't want to overfeed a baby. All right. Okay.
Mhm.
And if people think, okay, I have a bottle, I'm just gonna keep feeding this baby and maybe he'll sleep more. No, his little stomach is very, very small, so he'll just spit up. Okay. And a lot of babies spit up when they get too much in their system. Now, babies receive vitamin K. Now, HESI likes vitamin K. We'll tell you, has been on past HESI tests. And they get the vitamin K. And where do you give that vitamin K? What muscle?
In the thigh.
What's that called?
The gluteus,
Lateralis.
lateralis or something.
Vatus lateralis, right? Okay. Not the gluteal. Did somebody say gluteal? No.
I can't pronounce it, but it's the L one.
Okay.
Lateralis.
Just don't put gluteal. Okay, thank you. All right. Vatus lateralis. Okay. And then you remember his little intestines. Remember, baby, they're born with everything they need. All the little organs inside, but everything has to mature. Like their liver. Their liver is immature when they're born. So it takes time for it to mature. That's why they can get yellowish skin. is because the liver can't keep up with the amount of amount of bilirubin, right? Can't break it down. And so what happens is it accumulates in the body and babies get yellow. All right. Stools. Meconium is your first stool. It happens the first 48 hours. Then as you get, mommy's breastfeeding the baby, so we get maybe what? We get loose greenish yellow, right? That's more of a transitional. And about fourth day becomes yellow and seedy, especially with breastfeeding. And breastfeeding is the best. And breastfeeding, the stools are just a great consistency. They're not hard or anything. And they have about 3 to 6 stools a day. Okay. Remember, babies are going to be responding to feeding cues. So you want to assess, if you're working on a mother-baby unit, you want to assess these feeding cues of mommy picking up when the baby is hungry. Okay. And I tell you guys, the first feeding has to be observed by the nurse. The reason why is I want to make sure this baby is able to swallow. Okay. Okay. All right. So the nurse is caring for a breastfed newborn. So what will the nurse expect the stool color to be in 5 days after birth?
Yellow.
Yellow.
Oh, yeah. Okay. Now this is a really good slide. This is on the skin of the baby, integumentary, right? So you have a baby with vernix. Look at this baby. Woo! That's a lot of nature's cold cream. All right. But what it is a protective covering. All right. And so if you have a premature baby, they have more of this on their body than, say, a term baby. If you have a post-term baby, which is a baby born after 42 weeks, you have very little left because it's all been used up. But this is what helps them, their skin, and it's good substance, keeps them from preventing any kind of fluid loss. And it was a protective covering while they were in water. Remember, they lived in amniotic fluid for like 9 months. And so if they didn't have that kind of thick covering, their skin would dry up. Apgar sinus we talked about already, and it is normal in the first 24 hours. And then we got to check and see if it goes on, that basically what's going on with the baby's circulatory system. We check the heart. We check the heart to make sure that all these shunts have now closed. So, we want to make sure that it goes away after 24 hours. Now, see the little blue feet? And that's why you have parents that will come out to you and say to you, my baby, is this normal? And you want to say yes. And when a baby's trunk is pink, when you have pink color, that means they have great circulation. Okay, there's blood circulating there. All right, and then you have these little white spots. What are these called? Little white. Yeah. And basically there are little sweat glands on the nose. And don't forget, infants, they don't sweat in the first 24 hours, So they have these little pinpoints, and mommies think the baby has acne. You just tell her, no, it'll get better. It'll go away. Then you have the nevi simplex, which looks like a stork bite. And there's, that happens on the nape of the neck, and it blanches easily. 80% could be newborn. These are pink spots around the nape of the neck. Now, what's this called over here?
Mongolian spots.
Right. And these are bluish and black in color. They're pigmentation, and they're most common on the back and the buttocks. Okay. And mostly on dark skin, like from Latin America, Africa, Mediterranean, it looks like a bruise. But, you can't rub them out. And I think that was a test question, actually. You can't rub them out. It will fade over time. Now, looking at this baby here, if you didn't know this baby had Mongolian spots, what could you also be very worried about?
Bruises.
Abuse.
Like bruises.
Yeah, like bruising. And I would be worried about a bruising and abuse. And so you got to ask the parents, about that. Okay, erythema toxin. This is a newborn rash and appears in the first 24 hours and can last up to 3 weeks. It does go away. There's no treatment required. And langugo, what's that?
Hair, hair.
Yeah, tiny little hairs, and they will go away. On a premature baby, you're going to have more hair. That's going to be, that you can see. On a term baby, you may have it on the shoulders and maybe on their ears. And with a post-term baby, 42 weeks and above, they're not going to have any. It's going to be gone. So right after birth, when the skin of the baby's trunk is pinkish, but the soles of the feet and palm of the hands are bluish, this is called
B.
B, yeah. All right. So here, we're going to talk about the head. Okay. So let's jump down to, part of the baby's vital signs, you're going to measure their head, and it just tells you how to do it from the top of the eyebrow to the widest part of the occipital. So molding. So thank goodness that the baby's able to kind of, when he's coming down, the pelvis, that passageway, his head can kind of mold. If he's laying low in mom's pelvis for a long time, this can be, a lot of molding can happen because he's molded to her pelvis, all right? But it does go away and it does get better, thank goodness. Now we have a condition called this caput succedaneum, which is swelling over the scalp. Okay. Now, what you have to know about this is this back of this head. This is like caput succedaneum here, and you can see the suture line. You can see that does cross the suture line. You see that? Okay. Okay. And it looks like a cap. Thank goodness it does go away. Okay. But it does cross the suture line. Now, if the baby has a cephalhematoma, this is, okay, so here you have caput succedaneum. Well, that looks like hematoma over here. That's like caput succedaneum. Okay, so here's the have a hematoma is right up on the parietal bone right here. See here, the side of the head. Now this can happen. And what happens, you see the blood? This is a collection of blood under the scalp. Now, does this cross the suture line?
No.
No, it does not cross because I'm showing you it's on the side of the head, right? Okay, so you don't cross the suture line where this one is swelling, but this one is only fluid, all right? So it's not as bad as this one. This was a collection of blood. So again, the baby's head has been low in the pelvis, and it could have been that it could be a forceps delivery. It could be what? It could be a vacuum extractor assisted device that can cause this, all right? So these kind of babies, though, because this is blood, and the blood's going to be reabsorbed by the baby's body. Think about it. That means I have extra circulating blood, right? And if I have that, I have extra bilirubin, right? And if I have an immature liver, right? Am I going to be jaundice? Yes, you will be jaundice. Okay, good. So you see how one thing led to the other. This takes a little longer to go down because the body is going to reabsorb that blood. Okay. And then fontanelles, the soft spot on the baby's head. You have an interior and you have a posterior. Now, if you look at the fontanelles and you see it depressed, like sunken in, right? That baby is what?
Dehydrated.
Dehydrated, right. If that fontanelle is bulging, it's just sticking up and bulging, what's happening?
Increased cranial pressure.
Yeah, you have increased cranial pressure. Yeah, exactly. So these two are not good. That's what, but when we're looking at the baby's head, we're looking for stuff. We look for the fontanelles. We assess the fontanelles. We assess the top of the head, if it's molding and how and what degree. And we can do the head circumference. And knowing that the head circumference should be equal to and no more than 2 centimeters greater than the chest. So, and these things go away. Okay, this will go away. This will go down. Poor little guy, cute little guy. And this will be reabsorbed. And this will go down. It disappears like caput succedaneum goes down because it's only fluid. This is blood, so it takes a little longer. And this is how you measure. All right, so on a newborn's head, the nurse knows the swelling of the scalp that does not cross the suture line. What is this finding?
B.
B. Good, good. Okay.
What?
If this is a weakness and if you find that you didn't know that, just write it down so you could go back and look it up. So what is the nurse's best response to a mother who is voicing concern about the molding of her 2-day-old infant? And you know, they do get upset about this.
B.
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 Right. It goes away, right? The baby's head formed to the shape of your birth canal. Okay, it'll go away. Don't worry, it'll go away, you know? Would you say a traumatic delivery can cause molding?
No.
Oh, no. Okay. And molding, it doesn't cause any problems. Just don't worry about it. Okay. So here are some signs and symptoms that you have to be worried about a baby. So remember, you always know normal, guys. When you know the normal vital signs, you can what? You can pick up on what's abnormal. So we know about respiration. So normal respirations are 30 to 60. So if you got too low, baby's some problems. You have too much tachypnea, you got problems, right? And then you know your normal heart rate. And so if you have bradycardia, that's a heart rate, what, less than 110, that's a problem. You're going to look for what? Respiratory distress, and we talked about this already, okay? And then, of course, the cyanosis, and we talked about acrocyanosis already. See, we did all this already. Now, the only thing I want to go over with you is meconium aspiration syndrome. That's when the baby had his first bowel movement in utero. Okay. The thing about that is when the baby's born now, okay, has delivered, you always want to make sure that you've got your wall suctioning set up so that we can suction the baby out as the head is coming out, as the head is out. Then we take that baby and we don't stimulate it to breathe. Okay. We take it over to the radiant warmer that's already hooked up. Okay. And they'll have RT in there, respiratory therapy, and have a NICU nurse in there, and they will go ahead and do more suctioning to the baby. And of course, whenever you're suctioning out a baby, the NICU nurse is going to have her 2 fingers on the cord to pick up heart rate. We can do that very quickly by doing it that way. Okay, so these are something's not good, and so we put them into like a little mnemonic here for you. So you have wheezing. So you have what we call wet frog. Wet frog. So if a baby's wheezing, has a high pitch in the airways, not good. Effort. Is he got an inward movement of, the clavicle, the supraclavicle fossa, which is your chest retractions? Okay, not good. Is he moving that? Okay, and then tachypnea is greater than 60 breaths per minute, breathing really, really fast. Now the frog. Okay, nasal flaring, not good. So F for flaring. R for retractions. Okay, not good. Either intercostal or substernal. Oh, the substernal you see really fast, really easy. And then oxygenation. Okay, what's his color? Look in the mouth, mucous membranes. And then grunting. Grunting is sounds that occur when the baby breathes out, expiratory. So here's a picture about meconium stained fluid. So baby, what we're trying to do is keep the baby from getting meconium into his lungs. See here? Because this meconium is toxic. And so it can damage the lung tissue. And so you don't want that. So you want to get it out. So what we're going to do is we're going to suction. Okay, suction the baby and get as much out as you can. So he does not, when he takes his first breath, he doesn't suck all that into his lungs. These babies are sick babies. meconium aspiration syndrome. These babies are sick babies and they end up with severe respiratory distress and or hyaline membrane disease, we used to call it. And so basically, these babies will go to the NICU. All righty. So what symptom assessed in the newborn shortly after delivery should be reported?
C.
C. Thank you. Absolutely. Absolutely. Good. All right. Let's talk about genitory. How about this guy? He's kind of upset, isn't he? He looks like he doesn't know what's happening. Babies do, right? They do have pain. Okay. So this baby is set up for a circumcision. So I have him under a heat lamp or you can a radiant warmer. Gonna keep the baby warm because he's exposed. And we have him kind of strapped down because you have to. You cannot have a baby moving and trying to do a circumcision. No, no, no. So we do have him. We do protect his arm here by bringing down the sleeve a little bit more. Have a bulb suctioning right at bedside, okay? Because he's still got a lot of fluid in there, and they get very upset when they're on this board. Okay. Now the thing about a circumcision is you want to make sure that you have the parents sign the consent, all right? And because you don't, this is up to the parents. This is the parents. They can refuse. All right. So you want to make sure that you have that covered. And then you want to know after the circumcision, you want to note the first void. And then that first void, you got to call the doctor if he doesn't void within the first 24 hours. Okay. And then they come back and they have to reassess what they did. Newborns should have at least 6 to 8 wet diapers a day. I know you know that. And that by having that, we know he's getting the proper nutrition he needs, the amount of fluid he needs. All right. On the male genitalia, you have crypticism, which is undescended testicles. I haven't seen these on HESI. I have seen circumcision on HESI. And I have seen hypospadias. Okay. So when you're going to do a circumcision, you want to look at the penis first to make sure that the tip, the urethra, is in the middle of the penis top of the penis. If it happens to be on the side of the penis, that's a condition called hypospadias, all right? And so that baby's going to need surgery. So you would not do a circumcision on that little boy, okay? Because you need that skin to correct this abnormal positioning of the opening of the penis. So you want to make sure that you examine and make sure that the tip has the urethra in the right place so that it's not on the side, and such as hypospadias. Now I have seen that on HESI. Okay, because then they know the question, by giving you that kind of question like that, they know that about looking at the penis itself, knowing that where it should be, okay, and if it has something abnormal such as hypospadias, you want to make sure you don't do a circumcision. Okay, yeah. Question? Okay, all right. And then again, of course, if you're doing a circumcision, like I said, consent, make sure that this little guy has some kind of relief. We do a little bit lotion topical on the penis to help with pain, because newborns do have pain. Bulb syringe, and of course, keep the baby warm. Don't cold stress the baby. All right. Okay, and you're going to record the voidings, like I said, and then observe for bleeding. You don't need to put any kind of circle around anything. You just observe for bleeding, infection, and irritation. Now, in a female genitalia, they did have on HESI that pseudo administration, which this would fall under there. And what that is when the female genitalia, the external genitalia, is slightly swollen, and they may have a slight bloody vaginal discharge, and that gets the mom very upset. And that's because she's gotten hormones from mommy, okay, like estrogen. And so therefore, you know, that has caused her to have this little bit of bloody vaginal discharge. It will subside very quickly because she's not getting the hormone estrogen from mommy anymore. So that will take care of it. All righty. Here's my neonatal pain. Babies do have pain, and you have your different pain scales. And then you want to manage this neonatal pain, okay? And so, you know, again, local, topical, like I said, especially for a circumcision, really helps. Swaddling helps a little guy. That falls under non-pharmacological means, you know, and they may, you know, kangaroo care and distraction massage, and you know, just keeping him on his side and swaddling close. I mean, that works good even for the NAS babies. Okay, gestational age. I know this probably was, I think it's on your test. Post-term infant is between 42 weeks and 0 days and beyond. That's your post-term. So what happened is the American College of Obstetricians and Gynecologists, they went ahead and determined the gestational age. So what they're looking at is your preterm infants is less than 37 weeks. Your early term infant falls, now early term. Okay, so that's your preterm, less than 37 weeks. That's pre. Okay, so that's from viability up to 36 6/7. And then you got early term. So that means now your term, so you'll be between 37 weeks and 38 weeks and 6/7. That's your early term. Okay, so a full term baby is like 39 weeks to 40 weeks and 6 days, all right? And now we get to late term infants, between 41 weeks and 41 weeks and 6/7. Now, they put in this post-term infant, and this is like 42 weeks and beyond. Okay, this is, baby needs to get out around this time. Okay, this is late. This is, you know, post-term. I wouldn't say late because I don't want to get mixed up with that one. So post-term, they're going too far in gestational age. But, you know, we have great ultrasounds, and we can look at, you know, the biophysical profile. We can do NSTs. And so we keep an eye on these 42 weeks. But what you have to be very conscious about is that the placenta will get old, okay? Placentas usually start to get calcification around 41 weeks, and 42 weeks, definitely, they start to get old. And then you can see a difference in your babies. Okay, we kind of went over respiratory distress a lot as we were talking earlier. We talked about Highland membrane disease, that's what we used to call it. And then respiratory dysfunction and neonates. I always said that the biggest job this little guy has when he's born is to breathe on his own. You cut the cord, and we always used to say, cutting the cord, you're on your own, baby. And it's true. Their poor little lungs have to wake up, and they have to do the job. And they have to have surfactant, okay? Surfactant allows, you know, inspiration and exhalation. So you have to have surfactant. And a lot of times with your preemie babies, such as this baby here, even though we gave mom that beclomethasone we talked about earlier, the 2 doses to help increase the production of surfactant, it helps, okay? But now he came before we, you know, really get good results. And so now he's in the NICU, such as here. We can give this baby surfactant through the ET tube, okay? It's more of a liquid, it's a elixir, and we can give that through the ET tube. You're going to do oxygen therapy. You got to be very careful with oxygen therapy because you don't want to cause bronchial pulmonary dysplasia, which is toxic, okay, to the baby. And you give too much oxygen, you could cause that to happen. So we don't want that. So that's why you want to oxygen. You have a pulse oximeter on these babies, and you're monitoring their O2 sats. And if you get 92% or greater, you're in good shape. 92% or greater. Okay. And so therefore, if you get that, you don't have to increase anymore. Okay. Because you can do so much damage to a baby, not only blow out their lungs and have bronchopulmonary dysplasia, but they also can have eye problems as they get older because you damage the retina. Okay. So if you got a baby who is in respiratory distress, okay, again, tachypnea, greater than 60 breaths per minute, retractions, they have crackles, they have grunting, nasal flaring, and cyanosis, okay? All right, they do not, listen up, they do not have barrel chests, okay, not in neonates, all right? So these are your clinical manifestations. And I think you got these pretty well down packed now. All right. If you need if you like to look at the pulse oximetry monitoring and skills, I did put in here a page number and the skill number. Again, when you're doing bulb suction and you don't go directly in the middle of the mouth, no, because you're going to cause that baby to gag. So you're going to go in the side of the mouth, right? So you depress the bulb and start into the side of the mouth and let it come out, and you get fluid. You get a lot of fluid. I usually have a 4x4 on the side, and I can just squeeze out the fluid and go back. And we teach parents how to use the bulb suction because babies do have a lot of fluid. Okay, these are what we call associated complications. I already talked about bronchopulmonary dysplasia, and you can throw them in pneumothorax. See, their lungs, and they are just really tender. Did you see this little guy here? Now he's got a little good neurologically. If I'm looking at this baby in this picture, he's got a good reflex. See, what reflex is he exhibiting here?
Grab.
The little grasping, right? Grasping, yeah. And by knowing that, that's a good reflex. Then his little brain is working. And so we love to see that. And we're taking the blood pressure, and he's being on a vent, and he's being watched. And a lot of times you have to be very careful with all these different wires you have to protect their skin. Because you see this skin, you don't have a lot of brown fat on him. You can really see his veins, and you can really track these veins. Okay. All right. So we talked about the oxygenation and the retinopathy, and I did all that. Okay, so let's go on. Oh, here. So again, this is bronchopulmonary dysplasia. So it's just a toxic response of lungs to oxygen therapy. Again, we're going to have a pulse oximeter on them, and we're going to make sure that we don't give too much supplemental oxygen. All right. Some more complications of a preterm birth. All right, so you don't, and even with a term baby, guys, you don't want to cold stress these babies out. Babies have to be kept warm, and a pretermer especially, because they can try to keep themselves warm, increase their metabolism, and therefore they're going to use too much sugar to keep warm. They're really working hard. They go, nurse, just give me a blanket. And so they can run into what we call hypoglycemia. Okay, and we don't want that. And I told you they don't have a lot of brown fat, so they lose a lot of body heat, and they can have more hypothermia. So we keep them in a nice incubator or keep them on a radiant warmer where we can really watch them. Okay, all righty. Hypoglycemia is usually a good HESI question. And so what your baby's going to show you is that their cries are going to be not as boisterous. They're going to have a weak cry, and they can have tremors. And if you don't get in there, they can convulse on you. So I don't want that to happen. Remember, nurses, we don't want this stuff to happen. All right, we're gonna jump on this baby. And then in a pretermer, the glucose levels, when they get less than 40 milligram per deciliter, well, that's in a term, but actually 30 milligrams per deciliter in pretermer is never good. Okay, don't forget, now this baby is small. He's gonna have a condition called hyperbilirubinemia, too much bilirubin in his blood. Again, it's gonna lead into jaundice. Okay. Let's see. All right. On the NEC, the necrotizing enterocolitis, just know that breastfeeding has the greatest effect for lowering the risk, which is good, okay? Because it does happen, these preemie babies. And they get, their little stomachs get really distended and it gets real shiny because the skin is so thin. Now, it could be a question on proper size for if you're going to do a heel lancet like this baby here. You never go through the middle of the foot, okay? Never. There's too many nerves, right, going through here and major arteries. So you don't want to do that. So you're going to go, see here, you go on the side of the foot, please. Do not do anything in the middle. All righty. All right, cold stress. All right. It just is like what it says. You're stressing this baby out because you don't have the proper temperature for this baby. So he's cold. So what you're going to see is his skin temperature is going to go down. All right. Skin temperature goes down. And when that happens, now he's got to breathe fast because he's going to try to warm himself up. He's saying, help me, nurse. And he gets so fast that he has some periods where he loses his breath, APL. You have bradycardia, and you have that ugly looking skin called modeling of the skin. It's just terrible. And this baby's lethargic. All righty. Let's see here. This is another question. So 1 hour following a normal vaginal delivery, a newborn infant's boy's axillary temperature is 96. Okay, remember, nurses, we take temperature axillary, and his lower lip is shaking. And when the nurse assesses for a moral reflex, the little guy's hands just shake. He doesn't, remember the little C's, and he doesn't do this, he's just shaking. So which intervention should the nurse implement first?
Wrap the infant in warm blanket.
B.
D.
B. Okay, good.
Wouldn't it be D?
Oh,
Which one?
yeah, his temperature is not that low, is it? But his lip is shaking, and when she goes for a moral reflex, his hands shake. So which intervention should the nurse implement first? I'm thinking hypoglycemia.
Yeah.
Yeah. Okay.
Oh, yeah.
Yeah, right? Yeah.
Mhm.
Okay. All righty. How about our goals for the pretermer? So, thermoregulation, and I think HESI likes those. What time is it? Okay. I want to give you some HESI hints too. Kangaroo care, skin to skin, nutrition, gavage feedings. What does a nurse have to do before she gives the baby more food if he's gavage feeding?
Aspirate.
We want to suction them out.
Yeah, it's called aspirate. Aspirate before you give another feeding. Good. Okay.
Oh.
Good. I think, and that's the question on that. So I'm going to skip over that. And then our baby's special needs. So this is my nursing goals for the preterm newborn. Improve respirations. Now this could be for term babies too. Maintain body heat. Okay. Never cold stress these babies out, because cold stress leads to hypoglycemia, which leads to respiratory distress, and you can have too much going on. Conserve energy, prevent infection, provide proper nutrition and hydration, give good skin care, and observe the infant carefully and record observation. Always, guys, when you're working with children, from neonates all the way up, you want to always support and encourage the patient. Okay, so let's talk about these post-term infants. Okay, so again, we all agree that is the gestation that goes beyond 42 weeks. All right. What happens, I talked about already, the placenta can go dysfunctioning. It calcifies. It gets old. The time is up. It's time to get out of here. Significant increase in fetal and neonatal mortality. Yeah, I've seen them where patients that went beyond 42 weeks, babies didn't make it. Fetal distress, okay, they have more asphyxia at birth. They can be really born macrosomic, okay? And these big babies are now at increased risk for birth injuries related to the size of these babies. So which is not good. You know, you have a big baby and you want to get him out, and you get so great. You got the head out, right? But now you have these large shoulders that need to come out. And therefore you can, no matter, you already cut like a 4-degree episiotomy. You got her legs all the way back to her ears. All right, you got the picture? And so you still got the head, and you can't get the shoulders out. The only way you get the shoulders out is to break the clavicle. So now he's got to birth it.
Right.
Yeah. And so these babies too, because they're post-term, they can be more prone for meconium aspiration because they probably had their first bowel movement inside. Okay, because their GI tract, time goes on, and the baby's system says it's time. This baby should be born by now. All right, and so you have cracked skin and peeling is because that Vernix caseosa is gone. All right, there's no more of them. No more. It's used up, and so the peeling is because they've been in water with less Vernix. Okay, less protection. And then you have low blood sugar. These big babies are more prone to hypoglycemia. So let me see here. I'm going to skip over that one. And let's go here to hydrocephalus. We have a few more minutes here. So what's about hydrocephalus? We talked about this earlier, right? And we have a large, rapid growing head. All right. What happens with a hydrocephalus? You tell me. Anybody know?
Fluid in the brain.
Yeah,
See,
fluid, right.
yes,
Fluid in the brain, right. In the ventricles of the brain, right. You got it. So here you have ventricles that are just fine. Okay. The cerebral spinal fluid, is reabsorbed and it drains and it gets reabsorbed and it does wonderful. But here it didn't. Here it accumulates and there's no drainage. There's no reabsorption of it. And so what you have is you have enlarged ventricles. Not good. And so what happens, it makes this baby's head enlarged. All right. So these babies, the problem with this baby too is nutrition. And so because they have such a large head, you have to support the head while feeding them. And they all the time. And then you measure their head, just part of their vital signs. When you take blood pressure and everything else, you're going to assess for the HESI conference. Okay. So what are we going to do for this baby? Well, we're going to have to put in a shunt. I think we have a picture here. Yeah. So here's your shunt. So here's the tip. And the tip is in the ventricle of the brain. Okay. And so it'll take that fluid and will now drain it into the peritoneal cavity. And you have a pump here. And the doctor, what he does is he'll set up the parameter, how often he wants these pumps, this pump to be manipulated. And they do very well. And these children can have problems with seizures. And so they'll be maybe put on medications like phenobarbital. But you got to support the head. And they go in for multiple surgeries due to what? They're going to grow. Okay. Yeah, they got to grow. And when they grow, this shunt may not work as well. And how you know the shunt's not working is that the circumference of the head will start to grow again. It's tough. All right. So which assessment finding will the nurse expect for an infant diagnosed with hydrocephalus?
2.
2. Okay, can you tell me? Yeah, it is 2, a large and rapidly growing head. Can anybody tell me what a protruding tongue with a short, thick neck is? What's that indicative of?
Down syndrome.
Down syndrome. Good. Can anybody tell me an inward turning of the ankle and foot?
Club foot.
Left foot. Good. How about the hairy patch in the lumbar sacral region?
Spina
bifida occulta. Good. You got it. So this is why for Down syndrome, this is why our advanced maternal age moms, they opt for an amniocentesis. And we talked about that already and how we can look at those chromosomes. And these are the manifestations that you would see. And protruding tongue and simian creases are the ones that you usually see a lot on tests. Okay. but you know, their little toes are a little wider and the growth and development, they do go a slower pace. And they do very well. And we have a lot of things that can help moms and help these children to live very good lives. They are more resistant to infections. Gotta be careful, and to respiratory and ear infections. Okay, all righty. Now we can pick up if mom doesn't have this at early gestational time, we can do another test, and that's called the alpha fetoprotein test or the quad test. And that's usually done around 17 weeks. And so 17 weeks, and that basically can be, it's a screening test. You would never, ever make a decision based on a screening test. You want to go with the amniocentesis, because the amniocentesis is a diagnostic test. There's a difference. Okay, so which of the following assessment findings would lead the nurse to suspect Down syndrome in an infant?
B.
B, good. Okay, good. Okay, this is your cleft lip and cleft palate. Again, during the embryonic stage, it did not close. Okay, so with your cleft, your lip, your cleft lip, you have that fissure opening in the lip. See, you can see here. Okay, these are different degrees. The main thing about this is to have it repaired, and they usually repair it by about 3 months of age. It's hard. They can't, you know, they can't suck. And then they don't want the babies to cry, and you don't want the babies to be able to get at the suture line and to tear that open. All right, and not easy, not easy. So they may have to have elbow restraints to prevent the baby to scratch the lip. You know, it's awful, but it has to happen. Special syringe or bottle may be needed to assist in feeding. So these children do have problems with nutrition. Okay, nutrition. Now, after they have surgery, not only have to worry about nutrition, but you also have to worry about infection. But that's after surgery. You have to worry about that. And you have to worry about middle ear infections in the cleft palate, baby, because there's such an opening that can go right to the ears. So the parents, again, need a lot of support. So while assessing a newborn with a cleft lip, the nurse would alert that which of the following would be most likely to be compromised.
Succedaneum.
Exactly. When assessing a child with a cleft palate, the nurse is aware that the child is at risk for more frequent episodes of otitis media, which is an ear infection, due to which of the following?
B.
B. Good. All right. Good, good. Remember, anytime you feed a child with a cleft lip or cleft palate, you're always going to rinse the mouth out with water. Good. All right, bilirubin. So you got two types of bilirubin, guys. You got pathological bilirubin, and that occurs within the first 24 hours of life. And then you got physiological jaundice. Okay, so you got pathological jaundice and you got physiological jaundice. And just, you know, there's too many red blood cells. So what happens is that the liver can't keep up with all this, and you get a high bilirubin level, and therefore his skin turns yellow. Okay, so you gotta be careful with that, because you know, when you have pathological, you have that hemolytic disease called erythroblastosis fetalis, and again, you get an excess amount of bilirubin. Okay, and that's very serious. Okay, so that's why you want to look at the baby's skin when they're first born in order to assess the color, making sure that you don't see any kind of yellow, you know, going on in the first couple of days of life, you know, because that would be indicative of pathological. A lot of babies get the physiological jaundice, and if you live in the South, you put the baby out in the sun, and it helps break down the bilirubin circulating in the body. Okay, you don't want bilirubin to get too high, because you can have kernicterus, which is you can't reverse it, and they get delayed motor, and they can have hypotonia, and they can have brain damage. All right. All right, so again, this goes over jaundice and what it does. And again, I know you heard me say a couple times today, the liver is just unable to clear the blood of bile pigments, which results from the destruction of red blood cells. Trying to keep it simple for you. So, and also the higher the serum bilirubin levels, the higher the jaundice and the greater risk for neurological damage. That's why we do not want. Again, nurses, we are in the business of prevention. So if we see a baby that's turning yellow, we're going to jump on that baby and get the serum bilirubin level and make sure that we get that baby under phototherapy. And here's your phototherapy. Okay. Baby's under the lights. So make sure that you cover the baby's eyes during phototherapy to protect the eyes. The baby is naked except for a little diaper because they excrete the bilirubin through feces and urine. All right. So you want to make sure that you keep the baby under the lights, keep the eyes secure, just like if you went out in the sun and you wouldn't be on the beach in a hot summer in Florida with no sunglasses on. No, you wouldn't do that. Okay. And then this is your goals. Again, you're going to prevent kernicterus. Okay. So, all right. So 1 week old full-term infant is readmitted to the newborn nursery for hyperbilirubinemia. That's what it's called. What supplies should the nurse gather in preparation for the infant's treatment plan?
I should
A.
And you got it. You got it. This is an example of hip dysplasia. So hip dysplasia, what happens at the head of the femur is partly or completely displaced. What happens is that the socket for the acembellum, the top of the femur to go in for the acembellum is not good. It's not big enough. So what happens at the hip of the femur the head of the femur can't go in within that hip socket. And so that's what happens. So what are you going to try to do? We're going to try first to keep the baby's hips in a constant flexion and abduction for 4 to 8 weeks. Sometimes it works, sometimes it doesn't. We just try to keep the head of the femur within the hip socket so that it kind of stretches out that acembellum. And then you have club foot. And how you pick this up, you can see how these are not symmetrical, okay? And then you have the 2 tests. And the Ortolani test is the most common. You can actually hear a clicking noise. And so that's how you know that you have some hip dysplasia. The club foot is congenital, like we say. Here's your normal foot, and see how here. So the baby kind of walks on his toes and the outer borders of his feet. You can try stretching and splinting, and usually end up with a cast on their foot, and then they may have to have surgical intervention. But they can do a lot of great things with this today. All right. So how are we going to prevent spina bifida? How you tell me? You can. Folic acid. Folic acid. So here's a baby born with spina bifida. As you can see, you can see the sac is quite large. So that's why it's on the outside of the body. And if you don't put it with a sterile saline, with a sterile covering like a towel or something over it, it will dry out and it'll be no good. So what they're going to do, they're going to do surgery to help this baby. So you always want correct position to prevent pressure on the sac. That's the kind of test question you might see. And of course, keep it moist. Okay. All right. So I think we already said this, but the nurse is caring for an infant born with spina bifida myelomeningeal seal. So which intervention will the nurse implement to protect the sac?
2.
2. You got it. Okay. We have some metabolic defects. The maple syrup urine disease. Remember that? It had a sweet smelling. Think of your maple syrup that you put on your pancakes. It has their urine. The baby's urine is going to have a really sweet smelling urine. Okay. So but it's really life-threatening to the baby. All right, so a lot of times they have to do dialysis. They start out with hydration to see if they can help it. Sometimes they do dialysis. Yeah, this can be very deadly to a baby because it can put the baby into acidosis and therefore leads to death. Okay, and let's see here. PKU. I want to go over PKU real quick because we're running low now. A baby with these different eras of metabolism, such as maple syrup or glycemia, which is too much glucose in the blood, baby's blood, they can't tolerate, they can't break it down. They can't take the glucose and break it down to glucose. That happens. And so these different eras, including PKU, these babies look normal at birth, okay? But like by the time that you test, like in the urine, a lot of damage has already been done, especially with PKU. So what happens, we do a blood test. Now with PKU, it has to do with the intake of protein. So you have to be able to give the baby a couple days taking in the protein for it to show up. And what happens that they take in the protein, and protein, when it metabolizes inside the body, it breaks down into phenolphthalein. And these kind of babies that are positive for PKU are not able to break down the phenolphthalein. And so it accumulates in the blood and it can cause brain damage. So that's why every baby in the United States has a PKU test. Okay? All right.
Isn't it like more of like it could be like a dietary thing? It could like last like the rest of their life.
Absolutely. It's a lifelong change. They can't take in any protein. So you got to teach the parents how to read the food labels. Okay. And they have to go on special formula. They can't breastfeed because breast has protein and they can't tolerate it. They don't break it down. When they break it down, they have too much phenolphthalein growing in their system. All right, so here's your on an infant lophenolec or Phoenix 1. And these are synthetic foods, okay? Such as the glucose, the glycemia we talked about, that where they can't break down the glucose into sugar. They can't breastfeed either because breast milk has sugar in it, has glucose in it. Okay. And again, maple syrup, I said they appear healthy at birth. But they soon develop, and you pick it up, guys. That's why nurses, we're good, assessment, we're good smellers, we have good noses, we're looking, we're assessing all the time from head to toe, and we're smelling people. This is why, because we can pick up things. All right, talked about that, and I talked about that already. Okay. All righty, I'm going to jump right into neonatal abstinence syndrome. This is a condition where these babies are exposed to drugs in utero. Remember that? And so all these drugs cross the placenta barrier, and therefore an infant born to a woman who's addicted will, basically they'll suffer withdrawal after birth. And that's what you see. That's what you see. And they're very irritable babies. They could have long-term developmental and neurological defects. Swaddling these babies is the best thing that you can do. Okay. Just like I'm showing you a little picture here, because they don't sleep good. They're irritable. They're awake. They're breathing heavy. They respire. Their skin color is not good. Their temperature is unstable, and so, and they have what we call notable yawning. Okay. And that's been another one. And they have these cries that are like high pitch. Like I said, irritable. These babies can have seizures. And that's why, again, as a nurse, I want to keep this baby quiet. I'm going to do my care by what we call cluster care. I'm going to do everything in one shot so that I keep this baby, I don't interact with this baby too much, because the more you interact with these babies, the more irritable they get. And you want to give them love. You see this baby struggling and having withdrawal symptoms just like an adult would have, and you feel compassion, because that's what nurses are. We're compassionate people. But the best thing you can do is just to let them be. Not easy. Again, it's hard. Okay. Another baby I want to talk about. Here's your macrosomic baby. Okay, you can see what I mean. Delivering this baby, she would have a 4th-degree episiotomy, and you probably have to break the clavicle to get this baby out. You can see the size of his head, quite big, and his shoulders are big. He's a big baby. Okay, these babies are at high risk for birth injuries, at high risk for hypoglycemia, because just imagine I give you a Snicker bar all day long, every day for 9 months. Okay, so your blood sugar now in utero would be high. Okay, and so now you're born, and all of a sudden, what happens? All the Snicker
No more
bars.
Snickers.
That's right, no more Snicker bars. And so your blood sugar will go down. Okay, and that's what happens. So these babies, high risk for respiratory distress. These are sick babies. Okay, they usually go into the NICU because they have their insulin production is increased, and they have decreased surfactant for the lung development. They have problems. Moms that are type 1 diabetics, they have a tendency to have more babies born with congenital anomaly, and so they're at risk for all these different things. Yeah, it's hard. It's hard. Remember, they have the hypoglycemia, and then they can have low calcium. And on top of that, guys, they can have hyperbilirubinemia. You can see what this baby would have. IV, it could be under getting medications, probably have a central line. They can use in the umbilical vein from their cord. I mean, it's just horrible. And then they have phototherapy. And they will be there. They're going to be having all kinds of monitors on them because of respiratory distress. It's hard. Okay. So remember, know your math. So just go over your math. Remember your rounding. Okay. And read. If it says, to the nearest 10th, do the 10th. If it says the nearest 100, do the 100th. Okay. And but on and on. Okay. And your equations, D over H times quantity, right? You got that. Okay. I just put that in there. All right. So that's the end of my presentation. There's quite a bit. I want to give you some heads up too. Now, I think I have a few minutes here to do that.
Oh, I thought we was leaving. We didn't get our second break.
You know what? We're just so good today.
You're lucky you guys get breaks, first of all.
I gave one.
We'll hear the tips.
Breaking our class.
You want the tips? Okay, how about this? Okay, stay with me. Just don't come up. I want everybody to get their full attendance. Remember that. All right. So these are from past HESI tests. So they like breast engorgement treatment. So we went over that. C-section pre-op. I write these things down, guys. Carbopress. Chorioamnionitis. They actually had a question on cultural sensitivity. Fetal heart rate deceleration. Brooklyn, are you listening to me or are you on the telephone? Hey guys, come on, stay in class with me. Antepartum X-ray. They always have. Jessica, you okay? You look like you're tired. Okay. Antepartum X-ray. These are concepts. I can't tell you the questions because I don't have the questions, but this gives you a hint. And if you don't know some of this stuff, look it up. Apgar Score. We went over that. Bladder distension. Hey, Brooklyn, hang in there. And breast changes. Because you're right in the middle of my screen. Okay. The next test had Apgar Score again. Don't you think you're going to have Apgar in there?
Yeah, that's an important part after the baby's born.
Yeah, you got it, Brooklyn. You give it to me. Okay. And then impending delivery. They had an emergency delivery on here too. They have a lot of hemorrhage questions. Postpartum hemorrhage, preeclampsia, magnesium sulfate, respiratory distress. They had ambivalence on here. Ambivalence. Cord care. Episiotomy. And episiotomy. REDA, REEDA. Okay. And newborn, normal weight loss. Newborns do lose weight in the very beginning, and then they gain it back slowly. Okay. All right, vitamin K for the infant. Respiratory distress, your actions. How about this? Bonding with the adolescent pregnant woman. Bonding. Again, another one on respiratory distress, diabetes, gravidum para, alcohol, taking in mom's alcohol in pregnancy, NAS, okay, molding, all these things we went over today, Pitocin or oxytocin, magnesium sulfate, and get this, scope of practice for the LPN when you float to labor and delivery. That's a good one. Again, they had two more on respiratory distress, another postpartum hemorrhage, ROGAM, refusal of the ROGAM, delivery in the bathroom. I tell you, they've had this one on every test. Delivery. And I tell you what, I'm going to tell you something. I've had quite a few deliveries in the bathroom.
What do you mean, like delivery in the bathroom? Like what kind of question?
Well, because like I don't know the question, Elisa.
Okay, like top of your head, like what kind of scenario?
I can tell you. You know, you know, she's in labor. You tell her to go to the bathroom, you know, to empty your bladder, give me a little sample. She gets in there and she's
There's the baby.
She's ready to push. Yeah. What would you do? Okay, tell me. If you were in the bathroom and your patient goes, oh my God, and she's screaming, she's ready to deliver. Don't you need help? So isn't there?
Yeah, I'm thinking like you're saying the baby was already delivered. So
no, it's a delivery in the bathroom. It's okay. And so you need help. What are you going to do? You're going to push that emergency buzzer. I know it's been a long afternoon. All right.
Can you tell us what chapters to read in the HESI book for the maternity? You know
the HESI book is chapter 6.
Okay, thank you.
Is as under maternity.
Okay, thank you.
And I tell you, read every HESI hint. You know, read every HESI hint. And I have another one. Let me see. Let me just see here. Okay, that's the same thing. Okay. All right. And then we talked about hypoglycemia, breast changes, significance of NST. Oh, they always have a question on mastitis. Yeah. That's normal. Those are things you probably want to see. Okay. Let's see. Labor progression. You know the stages of labor, right? Which one is the longest stage?
First.
First stage, right? Okay. Tell me the phases in the first stage of labor.
Latent
phase. She's from
Active.
0 to 3 centimeters.
transition.
And you have the active phase, right? And she's like 4 to 7 centimeters. And then you have transition where she's 8 to 10. What I would know about those stages of labor is I would know when I should give an epidural or a narcotic to and when not to. Okay? That's how you can kind of blend that in. I would never give a narcotic to someone who's in transition phase, is because the baby's going to be born very quickly and then you would have a very sleepy baby. That's why you have Narcan on hand. Okay. Then the second stage of labor is what?
Birth of the baby. Getting ready to push
Active?
baby out.
The pushing.
Pushing, right?
The delivery.
Right, she's
Never mind.
completely dilated. She's 10 centimeters and she's pushing. Good, good, good. What's the third stage of labor?
It's when the placenta comes out.
Placenta delivery.
Yeah. The placenta is so important, guys. It has its own little stage, the third stage, because you want to make sure that comes out intact. We went over that because you can have postpartum hemorrhage. Good. What's my fourth stage of labor?
After birth.
Recovery.
Recovery, which is like 1 to 2 hours. And then you have what? 6 weeks postpartum. So I would know things like that. When's ovulation? If she has a 28-day cycle, when does she ovulate?
14 days after.
Okay, 14 days. Good, good. Let's see. When can I travel in pregnancy? Like go on a plane. I want to go to New York or something. How far?
2
Up
months.
to 36 weeks.
Up to
Yeah, 36 weeks. Good. Thank you.
Just don't
Okay.
get pregnant. It's fine.
Okay. So then if you don't want to get pregnant, what are you going to do? What kind of contraception are you going to be aware of?
Birth control.
Birth control pill. Lisa. Birth control pill, intrauterine device, right? Okay. So I would go over that. You know, a lot of times that they'll give you a scenario. You may have an adolescent who just gave birth. What kind of contraception would you like recommend for this adolescent to have? Well, you definitely wouldn't put them on family planning.
Abstinence.
That's another one. That's a good one. Abstinence. But you know, Alyssa, things are going to happen. Those hormones.
Would it be
estrogen,
condoms?
progesterone, and then that, what you call testosterone. Man, that stuff, you know, that just, those hormones go wild. So we got to give that adolescent some Depo-Provera, maybe an injection of Depo-Provera. So that's how you want to study those, okay? All right, guys, I had you here enough. I think I exhausted your brain. Hey, he's so cute. Is
Say
that
bye-bye.
yours? Bye. Oh, he's waving goodbye. Bye. Thank you.
Bye.
Keep
Thank
studying.
you.
Thank you. Have a nice
Keep studying, everybody. Keep going. I'll be here. I'm here if you ever need any help.
I have one question for you.